Hi, everybody. Thank you again for joining us. I am very excited to be here. And I'm a little nervous, to be honest, because it's my first time doing it virtual. So bear with us. I'm an adoptive mom of an amazing 11-year-old little boy. So I have that in common with some of you. And I'm the regional coordinator for the St. John area, for the greater St. John. And yeah, I think that sums us up, Maria? You want me to start into the slides? Okay.
Yes.
All right. So the prevalence, yep, sure. So prevalence of FASD, its leading cause of developmental disability among Canadian children. More than 3,000 babies are born each year. More than 1.4 million people are living with the FASD, and which is an estimated about 5% of our population is affected with each year by FASD. Based on the number of births in New Brunswick in 2015 and 16, we should be diagnosing between 250 to 330 children yearly. We're not diagnosing that many, but that's where we should be. And now going through COVID, those numbers are even at a higher increase because the stats, the new stats that are out, and I'm just pulling them up now, is that 57% of alcohol is on the rise and 46% of the pregnancies are on a rise. So there would be even higher amount of diagnosed children that we should be doing between yearly than the 250 and 330.
And at our clinic, we do 24 a year currently.
Right.
And we'll explain later why it is a long process.
It is. So as the world is facing a pandemic, so are we, and it's a medical alert that FASD is a serious public health issue. There are more than children born each year with FASD than autism, spinal dysphagia, cerebral palsy, Down syndrome, and SIDS combined. We are facing a crisis in the future with the amount of babies and such that are growing. Maria, if you have any other things to add in on my slides, feel free to, because I don't always have the examples that you may have. So please jump in.
Thank you.
Alcohol is a teratogen, which is any substance that can disrupt the development of the fetus and cause malformations or birth defects, including nicotine, radiation, alcohol, drugs, and chemicals. We don't know safe amount of alcohol is safe during pregnancy. We're not sure of the amount, Maria, right?
Yeah, so that's why we say zero alcohol.
Right.
And now you're going to say everything's a teratogen. And a lot of people do say that there are many things that are teratogens, yes, but we didn't know that the alcohol was such a poison to the babies in utero.
Right. Maria, just as we're going through the slides, I don't know what slide numbers were, so you'll have to cut me off.
Me too. Me too. That's what I thought this thing.
I was like, but anyway, I'll continue on and then I'll just like high five or tag you back in. Alcohol consumption in Canada, 80% of us drink. 56% of women aged 15 and older have reported binge drinking. The risky drinking is on the rise for women. I know in my area alone with some of my group of friends, it's becoming more common now for a middle-aged woman to go home and have that glass of wine and have that can of beer. And when you're out doing yard work, to have that sangria. It's more common than it used to be even 5 years ago. I find that it's more common, talked about in the offices and in your barbecue areas and stuff.
And it's not even just a common, but it's almost an expectation. People have, there's that social pressure to consume. Yeah, absolutely. Okay, so we do know that 50% of pregnancies are unplanned. And I think that statistic is even higher. I think it's 61% now.
It's 61,
Tanya, you can correct me. It's 61. So, and 62% of women who report drinking alcohol in the 3 months prior to pregnancy. And the thing is that a woman is not pregnant until she finds out she's pregnant. So the lifestyle is going to continue because she doesn't know she's pregnant. So that's why the risks are so high. And the big risk is the binge drinking. And I will explain that in a minute. Whoops. Given the high rate of the alcohol consumption, paired with the high risk of unplanned pregnancy, the rate of possibly having a child with FASD, it is a big cause for concern. So the brain is the first and the last organ that is affected throughout the pregnancy. So it is the only organ that is in development throughout, and I will show you the next slide to explain that to you a bit more. Whoops. Whoop. Maybe not. Okay, we'll get to that in a minute. So if you think of everything that the brain does for you, so the brain is in development from the brain stem, which is at the bottom part, going up towards the blue, the green, all over, up until the frontal lobe, which is that purple part. So that's where they have like the emotional brain, the problem-solving skills, planning, organization. So all of that executive functioning is really hard. And I will explain that more as we go along. I think it'll help you to understand better. I'm going to jump over the video because we won't have time to show. That's the screen I was looking for. So different parts of the body on the baby are in development at different times during the pregnancy. So you see the heart, you see the teeth, the ears, all of that. But the brain is the only one that is in development throughout. Okay. So if you look at the effect that the alcohol has compared to other, whether it be cocaine, cigarette, I don't know what's all up there because I can't see the top of my screen. Tanya, can you help me here?
Along the effects, there's alcohol, marijuana, cocaine, heroin, and tobacco. And by looking at the screen, we can tell that alcohol would have the effect with a low birth weight, impaired growth, facial malformation, small head, hyperactivity, poor feeding, excessive crying, respiratory problems, to mention a few. Where we see marijuana, cocaine, and heroin and tobacco may have less effects. They would only affect 3 or 4 of the 12 or so that are mentioned there. And alcohol can affect majority of all of it.
Mm-hmm. So the alcohol is the only one that affects directly, can have organ damage and birth defects. And of course, the microcephaly, the smaller head size, and the facial features. And we're going to talk about the facial features in a few moments. The thing is, there is no safe amount or type of alcohol that is safe. There is no safe time to drink alcohol, because I know for years, and I know doctors are still saying that sometimes a glass of wine is okay. Well, it's not really, and I'm going to explain that to you in a minute as well. So why do women drink? They don't know they're pregnant. They don't know how much damage it does. And it's not just a norm, it's almost an expectation in the groups, especially if you're a fun drinker. You know, people that their personalities change. We're not going to encourage them to drink, but especially the fun ones, we're going to really want to push for that alcohol drink. And some are coping. They're just trying to cope with some situations, and some do struggle with addictions. And I did talk to a mom today in tears. She's a nurse. She's with a doctor, and she still didn't know. She didn't know. She was living in another province, and they would drink wine during supper. And I'm going to talk to you about portions. It'll help you to understand better. Okay, so the thing is, some women will drink pregnancy and their child is not affected. And that's the truth. It's true. I had a mom who had 3 pregnancies. This was her 3rd pregnancy. She did have a large amount of consumption, and we brought her to clinic, and the child doesn't have FASD. It happens. The most important thing is considered the binge. And we're going to talk about what the binge looks like. So, Tanya, I have no idea where I'm supposed to be.
That's okay, me neither. So I can, it depends what the next slide is, because I have a little demo actually that I have planned. Good, this one, can I do the slide? Yeah. So in this screen here, that what we see is beer, cider, and coolers. 1 can, like 12 ounces, which would be your typical beer can. And what we learned in the previous slides is that a binge drink would be 3 to 4 drinks per occasion. So if we think of it as an occasion at a wedding, a birthday, or an anniversary, or a graduation party, generally, typically, people will consume more than 3 drinks. Wine is considered, 1 drink is 5 ounces. And for those of us that do drink some wine, we've seen the difference over the last few years in wine glasses. Before, we would drink out of your typical regular size wine glass that would hold about 5 ounces. And now we go to a restaurant or into home, and we are drinking out of goblets that are the size of our hand when we hold them, the same as the ones even without the stem. They hold generally about 9 ounces. So in retrospect, we're getting actually 2 drinks per 1 glass. So, you know, we went from this size to this side, and we're getting more. So but we say we only had 1 drink. We only had 1 glass, but in fact, this 1 glass would hold 9 to 10 ounces, which is really more than your 2 drinks per glass. So, you know, and even these little goblets that we use, the wine glasses without it, they hold right to here would be like about 7 ounces. So you're still getting, or even though it was only 1 glass, 1 drink. Go ahead,
There
Maria.
must be more than 7 ounces in 1 glass there, because I had measured 22 ounces in a regular wine glass that I was able to put, and I wasn't way at the top.
Right. Well,
So,
like this here wine glass, which is like the ones that the restaurants kind of use, they hold way more than the 9 ounces. Mm-hmm. Right. I was going to hope to pour water, into this to show like how many ounces it is to like do a visual, but I just didn't have it ready in time, unfortunately. But you're right. Like they do this, like 2 drinks in 1 glass. Right.
And more.
And more.
So, and that's what you are going to pour at home. At home, we're more generous with our portions, whereas in a bar and a restaurant, they are measured with the little jigger thing.
The little ounce things.
Mm-hmm.
Yeah.
So yeah, it does make a difference. And for the hard liquor, it's 1.5 ounce. So for men, a binge is considered 4 drinks. And for women, a binge is it's 3 drinks. So wine could be a binge. That's a thing. Okay, so what is FASD? FASD is a disability that occurs in children, in babies, and young adults and adults when alcohol is consumed during pregnancy. It is a lifelong brain-based, invisible. Most of the time it's invisible. And we're going to talk more about that to explain to you about the facial features. Usually it includes mental, behavioral, learning disabilities, and it is a spectrum. Children have a lot of other diagnoses. It's almost like the alphabet soup of diagnosis, but the umbrella term is FASD. And it does say that it is preventable 100%, but I always say, so are wars and so are famine. And what are the chances of that happening? There will still be people that are going to be hungry, and there will still be wars. And FASD, unfortunately, will still happen as long as people continue to consume alcohol. And like Tanya was saying, especially now with COVID-19 that has left us home and with more stress. It does affect the growth central nervous system, and sometimes it can affect the facial features, and we'll talk about that. Children with FASD have learning and behavioral challenges. So brain changes include parts that affect learning, memory, attention, social behaviors. It can be coordination. There can be so many things that affects. And it is a consistent pattern of inconsistencies. And before the meeting tonight, I was talking to a mom. She was telling me that at school, her son is really seen as non-cooperative because there's some days he just can't function. And she said, they have no idea how many times I repeat the same things at home. Repetition, repetition, repetition. We can't overemphasize that. But that's what our children need, a lot of repetition. And Tanya, you can add or correct me on that.
No, you're absolutely right.
Know.
Yep. It's the only way that they learn.
So for the facial features, that's right. So for the facial features, you're going to say, what's that about? This is when the facial features happen. Child have what we call the face of a FASD. It happens. So if you look at the top peak on the left-hand side, it's mom. That was like the beginning of the last period, okay? 14 days later, so day 1, it's ovulation, and it would be the fertilization. That means that was the day they make love, okay? The facial features happen between day 17 and 22. That 5-day window, that is when the facial features happen. That means that mom would have had to consume between day 17 and 22. Mom doesn't even know she's pregnant yet because she's just missed her first period. And moms only find out that they're pregnant. If I were to say by a raise of hand, how long before you knew you were pregnant? You are going to, people will say 8 weeks, 10 weeks, 12 weeks, 15 weeks. It can be many weeks before a mom knows that she's pregnant. So that's why we say lifestyle continues, because mom is not pregnant till she finds out she's pregnant. So here, 8 weeks, way at the bottom here on the right-hand side, mom has missed her second period. So that's 8 weeks. But between day 17 and 22, that's when the facial features happen. And please understand when we say, and I say this with the utmost respect, when I say those are the lucky ones, because we kind of see that something's not quite right, so we tend to be more kind and generous. So whereas the other way, we see nothing, so we assume they got this and everything goes to behaviors. So what we look for and what we say are the facial features, we measure between the left eye, we measure from one corner of the eye to the other. And so we measure that from one end to the other. Oh, what did I do? And then we measure the other eye, same thing, one corner to the other across. And then we measure the space in between the two eyes. So it's like we have a third eye. All spaces are equal when you don't have the facial features. When you have the facial features, the space is wider between the two eyes. So it's not like the third eye, it's not balanced, it's wider. They usually have a flat mid-face. It's considered but not measured. And we look at the philtrum. The philtrum is the space between the nose and the upper lip. And it's like we have 2 bumps here, if I can say. Tanya, if you can find a way to explain it better, please.
Nope, that's how I explain it, the 2 little bumps on your upper lip.
If they have the facial feature, the upper lip is smooth.
Yes.
There is no bump. And then the upper lip is very thin. So those are the 3 things that are measured. So the eyes, the philtrum, and the upper lip. And that's when we know if a child has the facial features of FASD. So if a child has the facial features, that is our confirmation of alcohol. We would need to have another confirmation. That is enough to bring a child to clinic. Okay, so Tanya, do you want to take it?
Sure. So some of the primary behaviors that we would see typically with our children with FASD would be, there would be impulsivity, poor adaptive behavior. They would have some poor attention skills, immaturity. These are the behaviors, or in our world, in our language, we would say symptoms that we would first see. And we'll talk about the symptoms and terminology later. You would also see some poor speech, socially and or mentally undeveloped, memory problems, inconsistent performances. And what we know with our children is the only thing that is consistent is their inconsistency, right? Next slide, please.
Absolutely. So one day they have the math, they can do all the tasks, they got it. And then the next day, poof, it's gone. So teachers will say, you're not applying yourself, you're not trying hard enough. And that's when it becomes hard for children, because they do try the best they can.
They do. Also, along with those primary behaviors, we would see difficulty generalizing, forming links, and making associations, difficulty abstracting and predicting the outcomes, over and under sensitivity to stimuli. There's sleep disturbances, the slow brain processing rate. They'll have no concept of ownership or no concept of personal space. So with the ownership, that's where our children will generally be accused of stealing, you know, where the phone's not being used by anybody and it's sitting on the table. So they go and they use it, and then they get accused of stealing the phone. But in fact, nobody was touching it, nobody was using it. So they just picked it up and decided to use it because it was just sitting there unattended. And that's where our children will be misunderstood, and they will be accused of stealing, per se.
And the personal space is the same thing. They're in everybody's bubble.
Right. And the slower brain processing rate, with that, you know, in person, I haven't figured out how to do it virtually yet, but in person, I usually will set a timer on the phone, and I'll set it for about 35 seconds. So if we were to do that, and if we think of the analogy of getting out the door in time for work and get our kids off to school, their processing speed is much slower. So we tend not to take that into consideration. So if I start my time now and I say, come on, Johnny, let's get ready for school, get your your boots and coat on, out the door we go. Well, Johnny hasn't heard anything, so he's just standing there. But time's ticking and I gotta go. Come on, Johnny, let's go. Johnny, it's time to go. And as each time that I say it, I elevate my voice and I become more of a rush. And it's only been 22 seconds. And chances are, little Johnny hasn't even heard the first word that you said. And that's only been 22 seconds. And I mean, some of the processing speeds, I know with my son, who does have a diagnosis with FASD, his processing speed is about 40 seconds. So I know to give the command in the short and simple terms and then wait until it clicks.
And you can kind of see with their nonverbal, they got it. Mm-hmm. Depending on the children, but there are cues sometimes that can guide us through that.
There is. So they seem perfectly normal, yet they have the hidden disability. Many of our kids, they don't have the facial features, so that's like Maria was talking about earlier, with the invisible disability. They look typically normal, but they have that hidden disability, which makes it so hard for the world around them to understand who they are and the way that they do things.
So what you will hear is he just doesn't try. He's an underachiever. He's not applying himself. She's not listening. She's tuning me out. Her family life is chaotic. It must be the parenting skills. Never met anybody more stubborn. Sometimes they're the class clowns. They're looking for more attention. But sometimes they're the quiet ones that don't want anyone to notice that something is not quite right. So from preschool to kindergarten, so you're going to say, when am I going to start seeing something? Well, when children are toddlers and as they're growing up, we are much more generous and forgiving until the children start school. So in kindergarten, they are either very quiet or really busy and can be aggressive. Usually it says here under the radar until grade 2. I tend to see it more with grade 3, because in grade 3, the expectations are that the child is going to be able to work more independently. And that's when it starts to show, because they can't work independently. They need more help and assistance. Grade 4 to 6, they start to have learning issues like math, reading, science. And reading, they may be able to read the words, some can, but they can't retell you the story or tell you what it was about. What's the plot? Some will go to the end and go back to the middle, and it's really hard for them to tell you the story. So school does become a nightmare for children with FASD. They start to have suspensions from school because you can see it as misbehavior, non-compliance, they're not following the rules. But the thing is, they can police the rules. They can tell you, like at recess, I have some of my little children, they wear the vest with the X, and they kind of police the playground. They can know which Johnny, Sally, who did what, and they can police that, but they can't internalize it. So, okay. Grade 7 and 8, friends start to notice. These are the kids that are not invited to birthday parties, not invited to play dates. So they start to have low self-esteem, difficulty. Some of the kids can make friends easily, but they can't keep them for long. They'll hang out with kids who are younger than them. And we're going to talk more about that after as well, if we have time. And they start to have failures at school. So grade 9 to 12, that's when the social problems start. There's that peer pressure, and people will want to, they are so easily led because they want to make friends. So whatever somebody says, that's what it is. They become best friends in a day. So they will be, they are the ones that, okay, if you were my friend, you go in there and steal us those chocolate bars. There they go, without thinking of the consequences or what's involved. They can be drawn and led into a lot of negative things. They get expelled from school, or they will drop out. And those are the premature signs of the possible disrupted adulthood, because they start to have secondary disabilities. And we're going to explain to you what secondary disabilities are. So there is no cure for FASD, but we can really change their outcomes. When you understand when they have a diagnosis and we put in the proper support, because children with FASD, they are who they are. They can't change. We have to work around them and give them the support that they need to be able to learn, because they can learn. That's the thing. So what we want you to do is change the way you think. It's not that they won't, it's that they can't. It's not that they won't, it's that they can't. Please understand that it's not that they won't, it's that they can't. So we want you to start shifting how you see them. What if? What if it's not that they're bad kids? What if it's because they're frustrated? What if, rather than seeing them as lazy, understand how hard they've tried? What if they go, that you start seeing them, rather from being fussy and demanding, they're oversensitive? Or what about that thing that Tanya was talking about, where ownership, we see them as thieves, but they really don't understand ownership. They need our help to be able to learn those things. They can, but it will take longer. Okay, Tanya, do you want to take that one?
So processing information, I can start into it, but then if you could help me out on the end of like finishing it up.
Absolutely.
Information processing deficits can occur in 4 domains. When information is recorded, interpreted, restored, which is like the memory, or retrieved. Just because they're capable of repeating the information back does not mean that they understand it. They will repeat back to you exactly what you said.
Word for word.
That's just word for word, and that's just their words. That doesn't mean that they fully understand it. So if you're trying to show them the lock at the locker, you need to get them to show you exactly how to do that lock, exactly how to turn the lock and which process, left or right, that they have to turn it. For them to repeat it back to you, guaranteed they will be able to repeat it back to you word for word and not miss it. But get them to show you so that they can fully understand. And then also remember in the past slides where if the lights, if you think of their brain with the lights, Maria, you've taught me this analogy, when the lights are fully on, that's a great day. But sometimes when the lights flicker, then that light's not working. And if it's a day that their brain is flickering, that light's just not quite all the way on, they may not be able to get it that day, even though they got it the day before, because the light was fully on the day before. Maria, if you want to jump in, or is that?
That's it. Absolutely. Yeah. That was well. That's it. So we have to find another way. So on the day that, like Tanya said, that the light is blinking at school, that's the day they're going to back off and not putting as much pressure on the child to be able to perform, because my lights are not working today. I need help. Mm-hmm. So the next day we try again. So there's going to be many, many repetitions, but understand that they're not doing it to annoy anybody. They're trying as hard as they can. So one of the analogies for that is like we say, so this mother is teaching her daughter not to ride the bike on the street. So at that place on the street, mom will say, okay, you have to get off the bike and we're going to walk across. You got that? Yes, she's got it. So she's going to know exactly what she's supposed to do, get off the bike at that place. She's got it. She's going to turn around and go to the next street and run in front of a car with the bike, because she can't bring the information to the other place. So everything will have to be retaught. So if there's rules at school in the cafeteria, well, she won't or he won't know that those rules apply whether you're in the cafeteria or that you're eating lunch in the classroom. Will not be able to carry that. Yep. So those are kind of the kids that will get in trouble. Usually we say in gym, in the cafeteria, at recess, and on the school bus. Why? Because those are unstructured areas. It's almost like fair game. They can get into so many things. And of course, it's very noisy and very, if you think sensory, and we're going to talk about that in a minute. So I'm kind of getting ahead of myself, but we want to tell you so much. So at what the alcohol does to the brain, look at this model, okay? So on the left side, you see kind of like the normal function of the brain. So left brain, right brain, it kind of flows so well. So if I have to do a task, if I have to remember things, everything flows. But look at the right side. If I were to say to remember things or to do what's supposed to come next, it can be very hard for children. So look at that brain and look at what that brain needs to do right now. I'm asking a question. I really have to stop and think because I'm not sure what you've just asked of me. So we have to allow more time. So here, it kind of shows you, like on the left side is like the average brain. So if at school, the teacher said 2 + 2, well, in my brain, in my files of all those folders, I have math. So in math, in that drawer, I have addition, subtraction, multiplication, it's all there. So if I say 2 + 2, poof, the drawer opens. I know exactly where to go to get the information that I need, okay? On the right side, look at, it's like the files are all over the floor. I know you're asking me a question. 1, 2, then you're asking me 2 + 2, 2 + 2. Oh, that's math. Okay, so I have to think that's math. Then I have to go to, is that addition? Is that multiplication? Is that? So think of everything that the brain needs to do one task. That's a lot. That's asking a lot from a brain. So start with from the time you wake up in the morning, you open your eyes, or no, let's go back. First, you hear an alarm. You have to decide, am I opening my eyes? Am I going to just put my hand all over the place to try to find my alarm to put it to snooze? And then I have to think, okay, so today is Wednesday. Wednesday. What do I have on the schedule today? Can I call in sick? What do I have to do? Like, think of everything your brain does for you, even before your feet hit the floor. The brain is an amazing generator. It does so much for you, but we don't realize when there's a brain dysfunction, how hard it is for them to keep up in our world, with our expectations, of course. So think you can help by starting to notice the behaviors. So I always say behaviors are symptoms of something that's not working, because children will not have behaviors to want to do bad. They want to do well. They do want to please. So we can't fix children with FASD because the brain damage is permanent. We need to accommodate. So when you start to see behaviors, think, could it be? Could it be that they really don't get it? So when you don't know, we say always put in accommodations because it can help the children. And there's nothing here that would hurt any child. So when in doubt, start using them. And we say, sound the alarm. Okay. You want to go, Tanya?
Sure. Just before we continue on, I was just wondering about questions, if this would be a good time to...
Absolutely. Thank you. I never thought of that.
To throw that out there. Any questions
Absolutely.
or comments or anything like that from anybody? I could just take a second and wait.
Yeah, I just asked the question myself, see if there's any questions.
Okay.
Nothing so far. We did have a comment that someone really did not know some of the information that you were sharing, and that it explains so much. So they're happy to have the information. If anyone
good.
has a question, feel free to put it in the chat, and I will
Right.
let Tanya and Maria know. So I think
Awesome.
we're good so far. Thanks, ladies.
Thank you. So we'll just continue on, but again, just throw it in the chat. We're so passionate about it, we get talking and then we kind of forget that we don't want to leave you in the sidelines. Adaptation,
I forgot.
That's okay. That's why we're here together. So difficulty starting and stopping the activities. Many of our kids will be like this. So the adaptive and sensory are two issues that bring on classic FASD meltdowns, or the tuning out responses. And I really love this example that we use here at a daycare of little Joey, who's 8 years old, because it is a typical situation of a child with FASD. When I first read it this afternoon, I was like, that's my little Ben. That's exactly what my little guy would do. So little Joey is 8 and he's at a daycare and he's playing outside. Time is up and the kids are asked to come back inside, but he still wants to play and becomes agitated. The educator indicates the quiet corner is coming, at which point Joey hits the educator, picks up a toy and throws it, hitting another child on the back. He then runs inside and hides in the bathroom and is found huddled on the floor, sucking his thumb. If any of you are parents or educators of a child with FASD, that scenario is a snapshot of what could happen about 5 times in a day. So we can all kind of resonate. And it's that they don't want to go, they don't understand, they can't make that transition from one environment to the other so quickly. So that's where we would want to put in some tools and strategies of putting in timers, giving them a heads up of what to be expected. They don't typically do well with spur of the moment, right now I got to go do something. They need to be prepped and guided ahead of time. Maria, did you want to add anything? Is that good?
No, that was well said, Tanya. Okay.
Do you want me to continue?
Up to you.
You got this one? Or
Okay. So for language, we say that they kind of have the gift of gab. Some of them, they really can dog the talk, but they can't walk it. So they will talk, but they can't internalize it. So, and those are the ones that I find I feel bad for, because so like my two nephews, they were really big boys. So we kind of like at 2, they looked like they were 5. But as soon as they opened their mouth, we knew like what's wrong with them because of the way they spoke. But actually, they were only 2. So children with FASD can have that difficulty with language, that they can talk the talk, but they can't internalize it. So Maria is 8 years old. She never stops chattering, the little chatterbox. She can talk the bark off a tree, and she's an expert at tattling on other children, but she doesn't get how annoying she is to other children, even if it's explained over and over again, or trying her to get her to quiet down when we've moved on to something else. So her lack of understanding is clear from the blank look that she gets after an explanation. Those are the kids that will get themselves into trouble and will put them in timeout, and they're like, what did I do? They have no idea. They have no idea. So attention, so ADHD and ADD is usually some of the things that will be diagnosed first. I think, I don't know if I don't have many that don't have ADD or ADHD.
No.
Do you, Tanya?
No, pretty
Most of
well. All of them would have that diagnosis.
So
it's
I
like
think
having the
so.
little alphabet soup behind them. They always have so many overlapping diagnoses. That's one of them.
So they can be hyperactive and restless and may wander around the room. So our little Ronnie is 9. He can't sit still or pay attention. And so he's all over the place. And it's like he has little ants up his pants and can't stop. So they fidget, they move around, they get up, and and it starts to be annoying as they get older. So the reasoning. So the abstract concepts are really hard for people with FASD to understand. Anything that's not concrete. So Jasmine in grade 8, working at a grade 4 level and having a reading comprehension and grade 3 in math. So abstract concepts are really hard for her. No concept of time. So she will get into trouble when she's asked to stop a task to move on to something else, because to her, time stood still. And those are the kids that you can't get off their Game Boys or their, what other electronics are kids playing now?
PlayStations.
Thank you. This PlayStation, all that stuff. So those are the children that get into trouble. So that's why we recommend timers, things they can see. So either an hourglass, so something they can see the passing of times, and then you give them reminders. So if you want them to come off in 10 minutes, you're going to give them a warning. You have 10 minutes left. You have 8 minutes. You have 5 minutes. And that will help them to be able to transition. I'm not saying it's going to work every time, but it's much better than saying, okay, you're done. You've been at it for 2 hours, because they're not done. So memory. They really struggle with their memory, and they will get into trouble. Let's say at school, if there's an incident, they are going to repeat their perception, but their memory, they struggle. So they're going to put in a piece of something they saw on TV. They're going to put in a piece of something else. And to us, it doesn't make sense. That's why we say they would make the worst witnesses, because it is memory gaps. They really don't know. So this little 4-year-old can't remember what we do to get ready at lunchtime. So that is except when she does remember, which is about a third of the time. The educator thinks that she's manipulative without understanding that it is not intentional. They really sometimes cannot remember. Okay, Tanya?
So the sensory processing disorder is where the brain damage causes serious problems with data input, data organizing, and the output. It can easily have the meltdowns when overwhelmed with stimuli in their environments. They can easily just tune out when they're overstimulated. If they feel that they're in that environment and there's too much commotion and too much going on, many of our kids will just tune out, or you'll see their symptoms elevate. It can be one way or another. It can go whichever way. In this example, little Stephen is 6 years old. He still sucks his thumb at home, but controls this at daycare. He does, however, chew his clothing and twirls his hair, even to the point of pulling it out. Tags on his clothes, seams in his socks, bright lights, and certain smells paralyze him. He is obviously distressed to the point of a complete meltdown until someone removes him from the offending data overload, if they can recognize it, of course. So that is the key, is when you can recognize what they do when they're overstimulated. If it's like twirling their hair or picking, you know, my little guy, he'll pick his thumbs and he, you know, his little hangnails and stuff. So then I know that he's becoming overstimulated and sensory overload. Then I have to remove him from the environment and redirect him into something else. So it's very key to be able to recognize what it is that your child will do, or the little one that you're working with, when they become overstimulated or when their anxiety becomes up too high. What is it that what is their go-to? And once you are able to pinpoint that down, then you're going to be able to redirect them, and the meltdown will be less. And that's the whole thing when we say, you know, there's always a trigger to a meltdown, and it's almost like being an investigator, just to go and investigate what they were doing, because there's always that trigger. And when they're in a meltdown, it's too late. So it's important to try to see what it is that's triggering them beforehand, and then be able to remove them from the overstimulated area.
So for sensory, think of, it can be noise, it can be odors, it can be lights, it can be, like she was saying, like
sounds,
the texture of the on the body. And what'd you say?
Sounds.
What'd you say, Tanya?
Sounds.
And textures in their mouth as well. So those are some of the children, they hate brushing their teeth. So it's really having that understanding. Like I had a dad who said he's already tried, was it 30 kinds of toothpaste? I didn't even know there were 30 kinds of toothpaste that existed. But he was really trying to accommodate to see what she would be able to tolerate in her mouth, because she really struggled with her sensory. So we have some children that are oversensitive, and we have some that do not feel. So they're seeking because they don't feel like we do. So do you want to do this one?
So with the dysmaturity, nope, I got it. The chronological development of a young adult living. So if we think of this in this graph, this child is the actual age, the chronological age is of 18. And we can see down on the side, the expressive language is above 18. That's no shock. Most of our kids, they're very expressive with their language, and they'll be off the charts and probably have a better language vocabulary than some of us. We'll also see here that their comprehension, though, will be on a lower, like this, in this individual, their chronological age, their actual age is 18, but comprehension is like a 6-year-old. Their emotional maturity is of a 6-year-old. Their physical maturity is 18, so it's of their actual age. And that's where it can really be hard as somebody that works with a child with FASD, is because you're seeing that individual as an 18-year-old body, but we have to really remember where they are mentally. Just because they're in that 18-year-old body doesn't mean that the mind is 18 years old. That means that the mind could be of a 10-year-old. So we want to put the expectations of a 10-year-old on that 18-year-old body. You know, would we expect that 10-year-old to be able to ride that city transit bus? You know, but it's hard to remember that when we have the 18-year-old body standing in front of us, because we think they're 18 and that's what we see. Their social skills can be of a 7-year-old, you know, so that makes it hard when they have to pair them up with their peers, because they're in the body of an 18-year-old. So you think that they should be playing, you know, hanging out with and doing things with 17 and 18-year-olds, where in fact they're down at the age 7, where they want to watch that Blue's Clues or, you know, those video games and TV shows, more to the category of a 7-year-old, which we may seem, if we're not trained in whatever and whatnot, when we see the 18-year-old, we go, oh, but he's 18, he doesn't want to watch Paw Patrol. but in actual fact, his mind is of that age. And living skills, so they may be like, if they're actually just 18, it could be of what would you expect of a 10-year-old to be able to do with their living skills. An 18-year-old, we may expect them to be able to handle a bachelor apartment on their own. But in retrospect, would you expect a 10-year-old to be able to live in that apartment on their own?
And to pay the bills.
And to pay the bills and everything that comes with that.
Mm-hmm.
Yeah.
So this person, actually 18 years old, is graduating this year, will probably go to university or college, will have a student loan, maybe get a credit card, but look at the rest of the understanding, the comprehension, money and time concept. They are really going to struggle and it's not going to work. Mm-hmm. That's why they need help. So individuals living with FASD, they do learn slowly, but they can learn. So it may take them a while to be able to really master a task, but eventually they will get it. We cannot overemphasize enough repetition, reteach, often. What we want to avoid are the secondary disabilities for children with FASD, and those are because of that lack of understanding. They have been misjudged for so long, not having a diagnosis, lack of services and support. So many people with FASD develop secondary disabilities because of that lack of understanding and no treatment, and the misunderstanding of and mistreatment, really, because we don't understand. And so many of them have mental health issues, disrupted school experience, inappropriate sexual behaviors, dependent living. They really can struggle. So that's what we don't want for our children. So, whoops. I can't see the top of that one. Tanya, what does it say?
Individuals with FASD and learning. So individuals with FASD are affected differently, and they must be treated individually. Each child is unique, presenting strengths and weaknesses. With supports and educational modification and/or accommodations, some kids have graduated high school, others have even gone on to college, others have gone on and had successful relationships and marriages and raising children of their own. Some adults with FASD are found in a variety of occupations such as teachers, artists, counselors, administrators, computer programmers. You know, and it's just important to take each child individually and break up their strengths and their weaknesses. And then on their weaknesses or on their challenges, that's where you want to put your strategies, and you want to put there's not one recipe card, but we have some strategies that actually do work. And the repetition, as we mentioned previously, is one of those things that we go on, and we'll learn more as we go forward with the 8 magic keys.
So they do have so many strengths, and we always work with their strengths first, because with their strength is what they will be doing their livelihood with. Mm-hmm. So if they're good with animals, they're good working with older people or with children. So typical strengths that we will see, usually they are hands-on learners. So kinesthetic, energetic, and they learn by doing. And that repetition, something that we would get so bored at a job because it's always repetition, they do better with because it's repetition. So that's why many things will have to be tried to see what they will be best at, but they can do very well. They value fairness, but they can be rigidly moral. They express themselves well verbally, as we were saying. They can be good with animals, children. They're generally very affectionate, loving, loyal. They are the most loyal friends, gentle, determined, and they are so resilient. After everything they've gone through, that misjudgment, the punishment, the punitive, all of that, they're so resilient. Excuse me. So, putting in place some strategies before you know if the child has FASD will not hurt or harm in any way. If you're in doubt, if you think, could it be? we say start putting in some strategies. There's nothing here that would harm. So strategies that are here, it's just an overview. There's so many things that you can do. There's no magic formula, but we really want you to try doing things differently. Try it out and see what happens. So they may need the help of a specialist like a OT if they struggle with their balance. Like I have a little one who would always get in trouble at school because he was going up and down the stairs. And while he was on the stairs, if somebody would walk by him, he would, they said he was violent. He would push somebody or the child going by. But what it was, he had to work so hard at concentrating on what he had to do, putting one foot in front of the other, that it was throwing him off. So we got him to be able to come out of the class 2 minutes before the bell rang, and he was able to go up and down the stairs, and guess what? No more incidences. So they do better with consistency, routine, repetition, and structure. That we cannot overemphasize enough. Okay, Tanya, do you want to take it? I feel like I'm always asking.
No, that's okay. No, it's all good. They benefit from a room environment that is calm and orderly and organized. Auditory and visual distraction needs to be minimized to maximize learning. Individuals with FASD cannot be changed. The environment needs to be modified to encourage the positive outcomes. So our little ones that we work with and we have are not going to change the way they are. They are who they are in all their wonderful and unique ways. It is our responsibility to change the way that we think and we react and we approach and our environments that we work with with our children. If we find, in a school setting, majority of them, that classroom can be very overstimulated. It can be a lot of busyness, a lot of things going on. Somebody just drops a little piece of paper and that could, or a little pen or something on the floor, that would be enough for them. So it's so important to keep the environment calm and orderly and organized. And then with the routine and structure, Maria. Yeah.
Yeah. And also keep in mind your home environment. So at home, their bedroom, try to have minimal. I know some of the kids, they have so much stuff in the room, but if the child has FASD, you're going to have a hard time to get them to settle down into sleep because they see the toys, they're distracted. And then in the morning when they get up and you tell them to get ready, well, they see their little Ranger car or whatever, they are so distracted, they're going to be playing, and you walk in and it's like, what were you supposed to be doing right now? And in the morning, I don't care who you are, Mother Teresa, or if you have to be out of the house by a certain time, the morning is not, it's very hard with a child with FASD. So try to minimize those distractions. So in the bedroom, limited things like even Dan Budsky, he says a bed, a chair, one picture on the wall, and maybe one toy, and that's it. Yep. I have a mom who put in order what the child is supposed to wear in the morning next to the bed on the chair. So the clothes are laid out the night before. So Sally knows what she's going to wear the next day. They pick it out together, but it's put in order of what she needs to put on in the morning to try to help her to go faster.
Yep.
So we say start using the 8 magic keys. So that means it says for students, but it's for your children. Concrete, keeping things as concrete as possible. Consistency, repetition, routine, simplicity, specific structure, supervision. Those are the things, if you put those things in place, it will be so much better for children with FASD. Trying to keep those things in order. So that would be like having the whole, so you're having everybody over for Christmas. Well, and that's when our children with FASD will get into trouble because that structure, routine, consistency is not, it's not followed. So those are some of the things that, yeah, the 8 magic keys really work. So making sure you have that supervision. So little Johnny, you can keep an eye on him, but it can be a buddy. It can be one of the other kids in your household that can be watching little Johnny to make sure that everything is okay. And they can come and tell you if something is not going right. But Like there's some things that I see on Facebook, like family members will put things like little Sally got into the nail polish and put it all over the table, things like that. Well, children with FASD will certainly get into any of those things if the supervision is not there. So they need that external support to help them do better.
And the simplicity is one of the simplicity one was one of my aha moments, actually, Maria, is because one of the number one things that I had to learn was less is more with our kids. You know, like it was like all the commands is like they only hear every third word, right? And I follow that rule of 3 things in their room, and I do lay out the clothes, and I even have one parent that has in the closet a closet organizer with shoes, Monday, Tuesday, Wednesday, Thursday, so their clothes are ready for only 4 days and ahead of time, and then those come out on Monday and lay it on the chair. So I just wanted to throw that in with the simplicity.
Absolutely, and that is important. Those are some of the things that will help with the routine, and it comes with practice. So I have a mom who color coordinates. So one of her little kids' favorite color is blue. So she has the blue tube, the blue gloves, the blue jacket, everything is blue. What's hers is blue. Another one is pink. And I don't remember what the other color is, but, and that's how it works at their house, color coordinating. So, and as visuals, if you can have a visual schedule, and then if something happens differently that day, if you can put it up and give them reminders, it's going to help to avoid some meltdowns. So if you look at behavioral approach to the standard practice, we see a behavior, it's believed that the behavior can change. So what do? We give them timeouts because that's how children learn. But children with FASD will not learn from a timeout. So rather than giving them a timeout, we recommend giving them a time in. So what does a time in mean, you say? Sitting down with them and explaining to them what just happened. So what went down and helping them to understand. And then they're like, oh, they didn't realize. Because to them, their perception becomes their truth. So if they see it like an injustice, hey, that's not fair, then it becomes their reality. So that's why they need our help and with the understanding. And their neurobehavioral approach recognizes the etiology of the brain-based disability. It is the source of the behavior. They're not doing it to annoy us. They are not a problem, they have a problem. So they need our help. When people with FASD try to do what is expected of them, they really struggle. And that's where your understanding and your help and having just that lens of FASD will change the perception. So what's going on, buddy? What happened? Check to see what their understanding is of that situation. It will take you longer. I will admit to that, but it will save you many, many meltdowns. So they're often unable, not unwilling to really do this to annoy you. They're equally unable to retain information. So they have memory gaps. They're always in trouble and they have no idea why. So that thing with the reward and consequences and punishment, it doesn't work. So if you think they're going to learn from it, they're not. You're doing it more for yourself than for them because they are not learning from a timeout. So have rules in place, have structure. We eat at a certain time, we do this at a certain, it's almost like a military household. That's when they will do the best. The more structure, routine, and consistency that you put in, the better they will do. Make sure that the consequences fit the crime. But like I said, the consequences and timeouts and things like they're morally for you because they're not learning from that. Please do give them shorter consequences. Giving them, taking a toy away for a week, for them, it's forever. So never ask them why, they have no idea. And we always say, what'd you do that for? They don't know. And then we'll say they're lying because they didn't tell us what we wanted to hear. So if you ask for an apology, you'll get one, but they have no idea. And that's the thing. They're not doing it to annoy you. It's because they do have that physical brain-based disability. So it's like they had a wheelchair, we're taking the wheelchair away and we're saying, you got this, walk. When they can't, they need our help. Okay.
Yes.
So this is just showing some of the things that work better. So focus on solutions, not the problem, having those positive incentives and that encouragement and that self-talk is so important. Help the child reframe their work, provide crutches for the invisible disability. So it's kind of giving them the wheelchair that they need for those that can't walk. If you need a seeing eye dog, well, people with FASD need our help. So they need help with understanding. So use as few words as you can. Like Tanya said, they only retain 1 every 3 words. So tell them, you know that song, tell me what you want, what you really, really want. Well, tell them what you want. Walk rather than say, stop running, stop this, da, da, da. Tell them what you want. That's going to help them. Repeat, reteach as much as you can. Reinforce, recognize, encourage, and support. And limit the environment. So transitions, prepare for transitions using visuals and auditory cues. That routine is so important. And if you know something is coming, let them know in advance. So at school, we say, if there's going to be a fire drill today, you let the child know there's going to be a fire drill. So recognize triggers, read their body language. That is going to so help you to be able to know when something is coming because you know your child. You know, I hear parents all the time say, I just knew when Johnny got off the school bus, he didn't have a good day. There's your cue. So those are some of the things that are going to help you if you can read those cues and having some things to help them with their sensory. Be concrete. Don't assume anything. They really do not have good problem solving skills yet. That has to be practiced a lot. Be attentive to when they start to dysregulate and they need help. They have an invisible brain-based physical disability, but they do have the same hopes and dreams as we all do. And please look at their qualities, their abilities over their disabilities. And really think about it, guys. They go back to school the next day. They keep going back. Imagine how much courage that takes, just that. And you ask the kids and they'll say, I love school. So every day is a new day. It's a new beginning. So that's how to reach us. I will also be able to send Patricia each regional coordinator's name and phone number to cover your regions because we do cover the whole province. So now, questions and comments. So do we show the videos first before we go to the question?
Sure, if you want to do that, yeah.
Let's do that. Let's see if I can make that work.
Dear teacher, I know it doesn't always seem like it, but I really do want to listen and learn.
It's just my brain is kind of different. So this is what I'd like you to know about me. I have to move, or I really can't pay attention.
Even though I'm not looking at you, I can still listen to what you're saying.
If you tell me, sit up straight, now I have to use all of my brain to do just that.
It makes me feel sad when you tell me to try harder, even though I've already tried as hard as I can.
I actually listen better when I'm rocking in my chair. When you give me a bunch of directions, I start to think, I will never remember all of this. Sometimes my mom or dad ends up doing all of my homework. So here's how you could maybe help. Let me get up and move while I'm learning.
Let me look wherever I want when you talk to me.
Let me rock or slouch in my chair.
No matter what, please don't take away my recess.
Give me home, I could do all by myself. Make directions very short.
Just ask me, what does your brain need right now?
And one more thing. My brain might be different than yours, but it's still amazing.
Sincerely, your student.
Your student.
Your student.
Your student.
All right.
And if anybody wants to, feel free to share your video now if you like. I know today was a little bumpy, but if you want to come on screen with us, please join us. It's nice to see some faces. And then feel free to throw in your questions in the comments and we will get to them as soon as we can. So
we would love to see your faces, to see who we've spent the evening with, especially during these amazing videos. So this video was done by over 70 people with FASD between in the UK and Australia.
I can feel safe and free. I know that I'll get there. Walk along with me.
I am not just FASD. Give me space and let me be. I'm unique, I'm different. There's so much I can do. I'm vulnerable, amazing, caring too.
Doing people wrong, so much I can achieve. It's a disability, not an infectious disease. Please don't see my angry scowl, see my friendly smile. Please don't see the worst in me, just stay here for a while.
I can feel safe and free. I know that I'll get there. Walk along with me.
I never lose my balance, spin on a slant. I also have a magic nose. I smell things others can't. I can be so funny. I tell you it's all true. I'm also very gentle, but a little rough too.
Many times I hold confusion, many times I'm holding pain, many times of finding what you say won't work inside my brain. I don't know expectations, so I'll often play the fool. Other times I might stay quiet, not interact at all.
I can feel safe and free. I know that I'll get there. Walk along with me.
I see the world with different colours, and I play a different way to the others. The alcohol got in my brain, but I still laugh and smile the same. Because of my pain, it's my Groundhog Day. Groundhog Day. Groundhog Day. Every life is precious, that's easy to see. I want to show you all my skills to show the world me.
I can feel safe and free. I know that I'll get there. Walk along with me.
When I'm happy I will like, when I'm angry I'm Darth Vader. It's not my fault that it affects my brain with my anger. The worry one wiggles in my tummy when I'm sad. My busy brain won't switch off and that makes me feel better.
I'm sure my brain isn't mine, someone else is doing it. In bed it's a volcano, after meltdowns can't remember it. I'm not invisible, not different as it seems. It's a difficult condition, but I still have visions and dreams.
I have FASD, walk along with me.
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 I have FASD, walk along with me. I have FASD, walk along with me.
I have FASD, walk along with me.
I have FASD, walk along with me.
I've got FASD, walk with me.
There we go.
Thank you for sharing that for us, Patricia. And that's just what we need. Our kids need us just to walk alongside of them and help them get through and build from their strengths and see them in the area that they are, see who they are and their being they are.
Because
Maria?
if you go into the world, it's pretty amazing.
Sure is.
And I can promise you one thing, out of all the children I've fostered, the children that I fostered that had FASD and I didn't know are the ones I remember the most because they taught me lessons. What happens
if mom doesn't admit to alcohol consumption or if the bio mom isn't involved at all?
That is the one that we struggle with the most. So if that happens, we try to find out does anybody know if mom consumed during her pregnancy? Was anybody witness to it? So her partner, the grandparents, we need 2 confirmations. We need to know, and that we would need to be on paper, and we're gonna, because that's proof. So we do need, because if not, we're just in the wind. We have no idea and we don't know what we're working with. So we do need to have a confirmation of alcohol.
So without confirmation from the birth mother, there's no diagnosis?
No, that's the sad part. So far, in 2021, February 17th, this is where we are. So far, we need some kind of confirmation.
If a child does not present with facial features, how early can they be diagnosed? Is it only through brain scans that they get the definitive diagnosis and mom's testimony of alcohol use?
That is a great question. And thank you for that. So less than 10, what we know is that less than 10% of our kids will have the facial features. As far as early being diagnosed, if they can do facial rec measurements, and if they have the facial measurements and all 3, then they can go ahead with that diagnosis if they're young, like under the age of 6. But like I say, less than 10% of our kids will have the facial features. So then they would have to ideally make a referral and come to a clinic, the Centre of Excellence in Moncton, and be diagnosed through there, which is about a week-long clinic. And generally, the child would be above the age of 6 when we would like to see them come through clinic, and they would meet with a psychologist who checks 7 parts of their brain, pediatrician, which checks another part of the brain, OT in language and speech. So there's a full week-long of assessments done to check all 10 brain domains, and then we go on through that. So, I hope, Krista, that answered your question. As far as definition of diagnosis and mom's testimony of alcohol use, we would require with Centre of Excellence that we need the confirmation of alcohol to bring a child to clinic. So with having said that, the best form is that we can have that conversation with the biological mom and get that information from her so that we can best service the child and everybody involved.
Someone who's adopted from the early infant list, so that means they adopted a child below the age of 2, and I think the child's quite young actually. What they're wondering is, they're saying there is in the birth records, there's indication that there was drinking throughout the pregnancy, but that at the 5 months checkup with the doctor indicated that there is no signs of FASD and that there's no need for a follow-up unless there are other indications later or the child starts to show some issues. So the question was, does that mean now, even though they know that there was drinking during the pregnancy, are they now safe to assume that this child does not have FASD, or do they need to have the child reevaluated at a later time?
I would definitely suggest that the child be reevaluated at a later time. The age 2 is very young because, as we said a few slides ago in the beginning of our presentation, is that up to like grade 2 level, we are easy to excuse their behaviors. You know that they're too young or they're just catching up and whatnot. And because that there is a strong history of the alcohol, then I would definitely be saying, please put a referral forward to the Center of Excellence and having an evaluation done. There is a little bit of a wait list for that, but it would be something that I would be recommending to go forward with as a referral. So reach out to, which they can self-refer. They don't need to have a referral through a doctor's office. They can self-refer. A parent or guardian can do that, a social worker. A school can do it on behalf of and work together with the parent. And then they can send it through the Center of Excellence, or if they know a local coordinator, then by all means. I hope that answers it.
Okay, thank you. We do have another question as well. They're asking, how long has this center been running? So I think that's a broad question because there's more than one branch, right?
So the center has been running for over 5 years. I think they're entering their 6th year. Maria, she has been with the Center of Excellence since the very beginning, and she does the Moncton region. I have been with the Center of Excellence for just over 2 years, and I do the St. John region. And then we also have somebody in the Northern region, also Fredericton region, Aboriginal liaison. So we're kind of spread out all over the province. And so yes, we've been up and running for over 5 years.
Let's say that a child does get referred to the Center of Excellence. So what happens on the day that they go and visit you guys for the first time? They come with their family, and what can they expect?
So what they'll expect is that they'll arrive on a Monday, and they'll generally meet with our psychologist for the full day and do a round of testing with her. And then on the next day, they'll meet again with the psychologist in the morning and break for lunch. And then in the afternoon, they'll meet with OT or speech, generally not at our Center of Excellence, not at our center that's on in Plain Street. And then Wednesday morning, they'll meet with either OT or speech, whichever one that they did Tuesday afternoon. Also meet with the pediatrician Wednesday and Thursday, Wednesday afternoon. And then Thursday morning, we meet as a team and we collaborate and we kind of go over all the tests and their findings, and we come up with, we have our discussion and we meet with the family on Thursday afternoons. It is a long and tiring week for our families and our children, but it is thoroughly done, and it is, the families come out with a full doctor's report with, Maria, at least, I dare say like 50 to 100 recommendations through the center.
Yes.
If they have,
and that's kind of the recipe where your child is going to be able to function at his or her best. So you will have the recommendations from the occupational therapist, speech and language, psychologist, and the doctor's recommendations. So you will walk away with a preliminary report. Then a couple of months later, you'll get the final document with all the details of all the testings that were done.
So that's the.
So can you see my screen?
Yes, we can.
I can.
Yeah. So that's the general experience when a child gets referred to and actually gets to go and be evaluated at the center. That's a week and then the report. Okay. Thank you for explaining that, Tanya. I believe too that if you go on your website, there's a video that takes people through the center so you can prepare your child ahead of time and they sort of know what's happening. So it's not quite as daunting or as scary. And we can share that when we share the presentation as well.
And also before you come to clinic, you'll work with your coordinator in your region. If you're in the Moncton region, then you'll work with Maria or myself in the St. John region, and we'll be working very closely prior coming to clinic, and we'll be doing our best to help prep you and your family for clinic week. And we'll be there on Thursday with you. Even after tonight, feel free to reach out to Maria or myself or Patricia and send questions. And Maria and I will, if you reach out to Patricia, she can reach out to us and we go back, or just reach out to Maria and I, and we will be happy to give out some more information or even the questions Love it.
Does anyone have any other questions while we're still online? We can stay on a few more minutes. No. Oh, thanks for the kind words, guys. That's good.
Oh, thank you.
Perfect.
It was our pleasure.
It was.
It was so much fun.
And if anyone's interested, Maria has agreed nicely to present for us again in the month of April. She's going to offer the same presentation in French. So if you have anyone, whether it's other professionals or people who work in the school with your kids, anyone who could take advantage of seeing the presentation in French, please let them know to join our Facebook page, and we'll make sure that they get an invitation. So. All right, guys, and please, this is again presented by the New Brunswick Adoption Foundation with the FASD Centre of Excellence. If you know anyone, any family members, anyone who is considering adoption, who has adopted or who's fostered, please let them know that they can reach us by going to our website at www.nbadoption.ca. We have a wonderful support network between all our adoptive and foster parents and even pre-adoptive parents, and we try and hold these webinars and these information sessions whenever we can to prepare our families and support our families for what it is to bring these children into your homes. So please feel free to share that with everyone, and we'll make this webinar public again once it's all fixed up, so you guys can share it. All right. Well, if there's, I see there's no other questions, so if everybody's ready to go, I'll stay on for a little bit longer if anyone wants to chat, but we can call it a night for now. So thank you, Maria and Tanya. It was really great.
Thank you. It was my pleasure.
Thank you.
Bye, guys.
It was our pleasure.
You may have heard about the New Brunswick FASD Centre of Excellence. Pretty cool name, right? Visiting new places can sometimes be a bit scary, so we thought we would take you on a quick tour to give you an idea of what you will see and what you can expect when you come to visit us during your 4-day assessment. Welcome to our lovely space. This is our waiting room that you can hang out in before and in between your appointments. It's got some really neat stuff to play with. Down this hallway are a few of our offices where you'll get to meet some very nice people. On day 1, you'll meet with one of our psychologists, and together you'll answer questions and complete different activities to help discover how your brain works best. Along with the Centre of Excellence, you'll also get to visit the Dr. George L. Dumont University Hospital Center 2 times during your stay, on both day 2 and day 3. Let's have a look and see what it's like inside. On day 2, you'll meet with an occupational therapist who will ask you to do some activities to see how you are able to move your body in different ways. On day 3, you'll go to a totally different part of the hospital that even has its own entrance. Here you'll meet a speech-language pathologist who is interested in seeing how you communicate, meaning how you interact with others, how you express yourself, and how you understand language. During your appointment, you'll get to point to pictures, answer questions, listen to stories, and explain or describe things. On day 4, you'll be back to the clinic where you started out, and you'll meet with one of our pediatricians. A pediatrician is a special kind of doctor that works with children and youth. The doctor will ask you about your overall health, then will take a little ruler to measure your eyes and take a look at your upper lip. They will listen to your heart and lungs with their stethoscope, check your balance, and see how strong you are. The most important thing to us is that you feel comfortable during your entire visit. Also on your last day, when your parents or caregivers are in a meeting with a doctor, you will have the chance to hang out and do activities with one of our super friendly volunteers. While you're in DEP undergoing your assessment, you and your family might get to stay at a hotel, or you could stay with family or friends. During the evenings, you will have plenty of time to relax and spend time with your family. Thanks for listening. We hope to meet you soon.